Welcome to the update from the Australian Government Department of Home Affairs, and thank you for joining us. My name is Amber Thurston, and I am the Acting Director of the Migration Health Section in Home Affairs Health Services Division. My colleagues and I are very pleased to provide you with this update today. As panel physicians, you play a critical role on behalf of the Department of Home Affairs and the Australian Government in supporting the integrity and safety of our migration program. Our other speakers will be Semra Capelli, Acting Assistant Director of Home Affairs Panel Management and Assurance Team, and 3 medical officers of the Commonwealth from Bupa Medical Visa Services. Bupa is the migration medical services provider contracted to the Department of Home Affairs to provide onshore visa medical services for visa applicants, and will be represented by Dr. Glenn Close, Principal Medical Officer, Dr. Fleur Nicholson, Senior Lead Physician, and Dr. Brinton Kathagama-Kanthan and Dr. Jane Phillips, who are medical team leaders. If you have any questions during these sessions, we look forward to discussing these at the conclusion of our presentation. Today's session is designed to provide you with important updates from Australia, including information on Australia's current COVID-19 measures for international arrivals, an update on Australia's visa and migration program, migration health policy changes, and panel management activities, including a demonstration of Australia's new online training module for all panel physicians. There will also be a detailed clinical presentation led by Bupa Principal Medical Officer Dr. Close. Australia reopened its borders on the 21st of February 2022. Incoming travellers no longer have to take a pre-departure test before boarding their flight to Australia, and cruise vessels are able to enter Australia. However, vaccination status must still be declared as part of the Digital Passenger Declaration, or DPD, or the Maritime Travel Declaration if travelling by vessel. Vaccination status may impact on whether a traveller may need to quarantine upon arrival. All incoming travellers will need to comply with the testing and quarantine requirements of the state or territory of their arrival, and any other state or territory to which they plan to travel. Visa holders who arrive in Australia may have their visa cancelled if they are not fully vaccinated, do not have a medical contraindication to a COVID vaccine, or are not in an exempt category or hold an individual travel exemption. Fully vaccinated for the purposes of travelling to Australia means completion of the primary course of one of the COVID-19 vaccines approved for use in Australia, or an overseas vaccine recognised by the Australian Government's Therapeutic Goods Administration. It does not include a requirement to receive a booster dose. Any claims for medical contraindication to a COVID-19 vaccination will be reviewed and considered by a medical officer of the Commonwealth. The focus of the Australian Government response has shifted to economic recovery as society transitions to living with COVID. High vaccination numbers of greater than 90% have contributed to the viability of this approach. Everyone living in Australia, regardless of their visa status, is eligible to receive a free COVID vaccination under the government's vaccine policy in order to obtain maximum coverage of the population. The 5 vaccines currently approved for use in Australia are Pfizer, AstraZeneca, Moderna, Johnson & Johnson, and Novavax. Also recognised for the purposes of travel to Australia are Sinovac, Covishield, Sinopharm, Covaxin, and Sputnik V. All COVID-19 vaccinations are recorded in the Australian Immunisation Register, or AIR. It is important to note that whilst it is not mandatory, the Australian Government encourages all visa holders to have taken a double dose of vaccinations with a view to following up with a booster. Failing to do so may restrict movement in Australia, as each state and territory has different requirements for entry and societal participation. Once in Australia, fully vaccinated means primary dose or doses and any relevant booster dose. Vaccination is not required for visa grant or as part of the immigration medical examination for COVID-19 vaccinations. Clients are requested to declare their vaccination status by consent during their IME, but are not required to. Although capturing vaccination data during the IME is voluntary, it remains very important in collating data for the Australian Government. We request that panel physicians capture which vaccination the applicant has taken via completion of the 951 form. Since the reopening of Australia's borders, there has been an increased demand in temporary visa categories, including visitors, students, working holiday makers, and business visas. As at the 30th of April 2022, approximately 1,159,000 visas have been granted to temporary visa holders this financial year, including over 196,000 student visas, over 71,800 working holiday maker visas, 48,600 temporary skilled visas, and over 716,000 visitor visas. Refugee and humanitarian cohorts remain a high priority for the department. This includes facilitation of travel in urgent and emergency humanitarian cases who have been granted a travel exemption to enter Australia. As at the 31st of May 2022, Australia has facilitated the entry of 5,500 humanitarian arrivals from Afghanistan, with an additional commitment to an intake of up to 5,000 entrants from Ukraine, around half of whom have already arrived, and who will be offered the opportunity to apply for 3-year humanitarian stay visas. As part of the skilled stream, the seasonal worker program remains a high priority with the Australian Government, facilitating the regular arrival of visa holders to fill labour gaps in the agricultural industry. Source countries for seasonal workers program by total visa grants in order are Vanuatu, Tonga, Solomon Islands, Samoa, Fiji, Kiribati, Timor-Leste, and Papua New Guinea. We are working to increase panel capacity in these locations. As at the 30th of April 2022, approximately 125,000 visas have been granted under the Temporary Resident Other Employment category, which includes the Seasonal Worker Program and Pacific Labour Scheme. Visa and migration programs are recovering from the impacts of COVID-19 and Australia's biosecurity measures. For the year 2020 to 2021, total visa lodgements were over 1.27 million, representing a decrease of about 77% compared to the almost 5.5 million lodged the previous year. For 2021 to 22, the total visa lodgements as of the 30th of April year to date stand at over 1.77 million. In 2021 to 22, Australia has given priority to the family stream, mostly partner visas. This is tracking steadily against the previous year and currently stands at 83,699 visas lodged as at the 30th of April. During 2021 to 22, Australia's focus has also been on both temporary and permanent skilled migration to improve the productive capacity of the economy and fill skill shortages in the labour market, including those in regional Australia. There is a growing focus on seasonal workers from the Pacific, who are instrumental in filling skill shortages in the agriculture and food industries. In 2021 to 22, as of the end of April, there have been 211,107 visa applications lodged in the Temporary Resident Other Employment category, which primarily includes Pacific labourers and seasonal workers. This is already the equivalent to 108% of the total lodged in 2019 to 2020 and 123% of the lodgements in 2020 to 21. Approximately 61% of these have resulted in a visa granted to enter Australia. This is on par with previous year's data. To boost these numbers, we are actively liaising with panel clinics in various regions worldwide, including in the Pacific region, and have received a number of expressions of interest from panel physicians wishing to join the Australian Panel Network. In addition to the family and skilled streams, Australia has prioritised our refugee and humanitarian visa program with a focus on Afghan and Ukraine applicants who are seeking refuge during the ongoing crises in their respective countries. Australia is able to offer a limited number of refugee and humanitarian resettlement places each year. Many more people apply to be resettled than Australia can accept. The humanitarian program continues to focus on assisting those in greatest need of resettlement, with intake drawn from a range of nationalities, ethnic and religious groups, reflecting global displacement arising from conflicts and persecution. The annual humanitarian program intake is currently set at 13,750 places. This includes both the offshore program and the onshore program, with the latter including people who have arrived lawfully in Australia and have then sought Australia's protection. Priority regions for the offshore program include the Middle East, Africa, Asia, and Central and South America. In recent years, around 55% of the offshore program has been from the Middle East, and around 20% each from Asia and Africa, with a smaller percentage from Central and South America. In 2021 to 2022, with the additional focus on Afghans, places for Afghans make up of around 40% of the offshore program, with 33% for the wider Middle East, 15% for Asian cohorts, around 10% for Africa, and 5% for the Americas. For Afghan nationals, in addition to the 10,000 places within the offshore humanitarian program already announced by the government on the 21st of January 2022, on the 29th of March, the government announced an additional 16,500 places for Afghan nationals to be allocated over the next 4 years at 4,125 places per year between 2022 to 23 and 2025 to 26. These are to be delivered in parallel to and in addition to the annual humanitarian program intake of 13,750. In conjunction with previous announcements, this brings the total number of visas available to Afghan nationals to 31,500 over the next 4 program years, which comprise 26,500 places under the humanitarian program and an anticipated 5,000 under the family stream of the migration program. Finally, to support persons leaving Ukraine during the current conflict there, on the 20th of March 2022, the Australian government announced a projected intake of up to 5,000 Ukrainians on 3-year temporary humanitarian stay visas to be granted onshore to Ukrainians who have arrived in Australia since the 23rd of February 2022. Each Ukrainian will need to undergo a medical examination and a chest X-ray prior to grant of the 3-year visa. The pandemic has impacted the refugee and humanitarian program operationally and structurally, resulting in lower resettlement outcomes and necessitating modifications to the processing model in order to sustain visa processing. The delivery of the program continues to face several logistical challenges due to COVID-19, including capacity limitations faced by key program partners, inability to access many refugee camps, reduced mobility of applicants due to lockdowns, rendering attendance for interviews and medical examinations difficult, and resource constraints at embassies due to workplace access issues for staff due to the impact of COVID-19 and broader government priority activities, such as providing consular assistance to Australian citizens. Travel restrictions continue to apply to non-fully vaccinated humanitarian visa holders who require an exemption to be able to enter Australia. The Department is planning a schedule to facilitate the orderly travel to and a smooth settlement in Australia of the thousands of Class XB refugee visa holders who were not able to travel when the border restrictions were applied. This cohort of around 8,000 visa holders is likely to require some medical assessment follow-up, as the medical clearance is likely to have expired given their immigration medical examination was likely to have occurred more than 12 months before travel. This financial year, Australia has offered humanitarian visas to special intakes of Afghans and Ukrainians in response to the conflicts in these countries, and these cohorts have required extensive programs of onshore health processing post-arrival. As at the 27th of May, there are a total of 5,515 Afghan clients onshore on subclass 449 humanitarian visas. Whilst these applicants did not have to attend an IME offshore, a condition of the 449 visa required them to attend a medical examination after arriving in Australia. As of the 27th of May 2022, 5,332 Afghan nationals have undertaken their IMEs onshore. This equates to 97% of the total of visa applicants. 325 of those screened have required a health undertaking. 44% of these were due to pregnancy, which requires the client to undertake a chest X-ray after they give birth, noting that this provision is not available offshore for countries with a higher risk of TB. Approximately 40% were due to suspected active tuberculosis. 50 were for hepatitis B, 8 for hepatitis C, 7 for syphilis, and thus far 0 for HIV. Some have multiple of these comorbidities. Also, as of the 27th of May, 2,697 Ukrainians of a projected cohort of 5,000 have been scheduled for priority health screening appointments onshore. COVID vaccination rates are low among the Ukrainian cohort due to vaccine hesitancy. Both the Afghan and Ukrainian cohorts receive further health screening and services provided directly by onshore refugee and humanitarian services providers. As you may be aware, each year the Australian Government releases planning levels for the migration program. The 2022-23 migration program will have a planning level of 160,000 places. The program has been designed to boost Australia's economic recovery and drive social cohesion outcomes in the post-pandemic environment, and as such will have the following composition. For skilled program, 109,000 places. This stream is designed to improve the productive capacity of the economy and fill skills shortages in the labour market, including those in regional Australia. For the family program, 50,000 places. This stream is predominantly made up of partner visas, with some parent and child visas, enabling Australians to reunite with family members from overseas and provide them with pathways to citizenship. The partner program next year will be demand-driven and will not be capped, so there will be increased visa processing to meet the demand and reduce current waiting times and queues. The special eligibility program will have 100 places. This stream covers visas for those in special circumstances, including permanent residents returning to Australia after a period overseas. Public health risk screening is completed for offshore visa holders who have not been able to travel within the first entry date noted on their visa. Once this date expires, the department must be satisfied that the visa holder remains free of active TB. For the purposes of a public health risk screen, the following additional health examinations will be required to screen visa holders for public health risks, more specifically, active TB. If the visa holder is 11 years or older, a medical examination, the 501, and chest X-ray, 502, regardless of TB risk level. If the visa holder is 2 years or older, but under 11 years old, a medical examination, 501, regardless of TB risk level, plus, if higher TB risk, a TB screening test, the 719, IGRA or TST. If the visa holder is under 2 years of age, a medical examination, the 501, regardless of TB risk level. Visa processing or other departmental officers will provide visa holders undertaking public health risk exams with e-medical exemption letters and information on the medical exam form, Form 26, and chest X-ray examination form, Form 160. These additional medical examinations cannot be recorded in e-medical and must be recorded offline on paper. They are completed and returned to the department via email. Departmental officers should provide these forms to the visa holder for their public health risk screening appointment along with a request letter. E-medical contains a tip sheet for Australian panel physicians to assist them in managing these cases. New latent tuberculosis infection, LTBI, screening requirements for healthcare workers and healthcare students will be introduced from July 2022. These are being implemented in order to identify visa applicants who, under policy, may be considered a public health threat if they intend to be involved in exposure-prone procedures without being aware of their blood-borne virus status. LTBI screening will be done through a 719 TB exam for visa applicants who declare their intent to work as, study or train to be a healthcare worker, aged care or disability care worker from countries deemed higher TB risk for the purposes of the Australian health requirement. These requirements are based on the Australian National Guidelines for the Management of Healthcare Workers Living with Bloodborne Viruses and healthcare workers who perform exposure-prone procedures at risk of exposure to bloodborne viruses. To avoid duplicate testing for these applicants when they arrive in Australia, it is important that you provide the visa applicant with a paper copy of their LTBI screening results. Don't wait for them to ask you. It is important that you print it out and give them a copy so that they don't have to undergo the testing again when they commence working in Australia. System changes are currently being made to incorporate this new policy, and further guidance will be provided in the panel member instructions, as well as a tip sheet on e-medical. Panel members are welcome to contact the department at health@homeaffairs.gov.au if any further information is required. These are ongoing policy projects and are key priorities for the Australian Government with regard to migration health. Number 1, an update on the removal of Appendix D from the panel member of instructions. Following comprehensive analysis of international and various countries' national accreditation standards for TB laboratories and directly observed therapy clinics, the Department has decided to remove Appendix D, which lists a number of recommended TB clinics and DOT centres from the panel member instructions. Instead, wording has been incorporated in the PMI to advise that panel members are responsible for ensuring that the laboratories used for sputum testing have either relevant International Organisation for Standardisation (ISO) accreditation, the equivalent national or state accreditation in the country in which they are located, or are working towards that accreditation. New applicant clinics will be required to advise of the accreditation standards met by the laboratories they use as part of the empanelment process. Migration Health will conduct assurance over this documentation periodically over current panel clinics. Number 2, Gene Expert Pilot in the Pacific. Australia recognises that a number of countries in the Asia-Pacific region do not have the laboratory capability to culture sputum samples for tuberculosis investigation in country. The transport of sputum samples to laboratories in Australia or other countries for culturing through the use of commercial couriers has historically been challenging due to concerns regarding the appropriate transportation of biomaterial, the resultant quality of the samples, and the challenges in providing assurance over this process. In August 2020, Australia implemented a pilot project in Vanuatu, Solomon Islands and Kiribati, with a control country in Timor-Leste, for the use of molecular gene expert testing of TB samples in country. The goal for the pilot project is to have 50 cases deferred for TB investigation tested using Gene Expert, at which point analysis will be conducted to ascertain the continued viability of this method of TB investigation from both a policy and a clinical perspective. Since the commencement of the trial in August 2020 to the end of April 2022, 145 cases in the pilot countries have been deferred for further investigation of TB. Of these, 44 cases, or 43%, have undergone Gene Expert testing, of which 2 cases of TB have been diagnosed and are undergoing TB treatment after positive results in Vanuatu. 16 cases are awaiting outstanding requirements, such as a specialist report or repeat chest X-ray. 20 cases were assessed as meeting the health requirement, and 6 cases were assessed as meeting the health requirement with a health undertaking. 8 cases, or 8%, have undergone sputum smear and culture, not Gene Expert testing, with negative results, of which 7 were from Timor-Leste and 1 from Vanuatu. 67 cases, or 23%, have not undergone Gene Expert testing and are pending further testing and investigation and/or repeat chest X-ray images. This includes cases still in progress. Further testing is dependent on visa applicants presenting for the required examinations. These applicants are being actively followed up by the panel clinics, with correspondence being undertaken regularly by Australia. 26 applicants, or 26%, have abandoned the IME process. These cases will be finalised as incomplete and will not be granted a health clearance. Panel clinics have referred these cases to the National TB Program of their respective countries for further follow-up in investigation under duty of care procedures. The targeted sample size for the trial is 50 cases tested with GeneXpert. A further 6 cases are required before the trial will be formally evaluated. Our third project is the Immigration Medical Exam Review that Australia has been conducting, which is part of a broad review of the settings of the IME for pre-migration health screening. The review seeks to provide assurance that we continue to screen for the right things in the right way, and that our pre-migration health screening parameters are relevant and future-proof. Due to the scale of the IME review, we have broken down the project into like conditions and cohorts, and progressed external consultation on this basis. Some short-term review recommendations have progressed already, such as the removal of the fundoscopy test in the IME. Other sections, currently in progress, include reassessing the requirement to conduct urine dipstick testing for all applicants greater than 5 years old, and potentially replacing this with a serum creatinine blood test. As the IME review progresses, we may reach out to panel clinics as required for input on various aspects of the project. Any changes will be communicated with you beforehand through eMedical and through updates to the panel member instructions. And finally, our fourth project, an update to the Departure Health Check supporting material. Australia offers a Departure Health Check, or DHC, to refugee and humanitarian clients, which is a voluntary health check conducted by the International Organisation for Migration up to 3 days prior to the client's confirmed travel for Australia. The DHC is intended to ensure that offshore refugee and humanitarian visa holders are fit to travel and to identify any specific health needs which may require intervention or support prior to travel, during travel, or post-arrival. Our team have been reviewing the DHC guidelines, including the medical escort process and health alerts. The aim of the review is to assist with refugee and humanitarian health, resettlement, and continuity of care onshore in Australia. If you have any specific comments regarding the DHC that you would like to communicate to us as part of the review, please email us at health@homeaffairs.gov.au. Active TB is the only medical condition that, in itself, prevents the grant of a visa as prescribed in the Australian Migration Regulations 1994. An applicant diagnosed with active TB must satisfactorily complete the required treatment, and a medical officer of the Commonwealth must be then satisfied that the applicant will not be a public health threat before a visa can be considered. Of the 656,090 IMEs completed in 2019 across 163 countries, 626 visa applicants were identified as having active tuberculosis, representing an offshore IME TB rate of 95 per 100,000 IME caseload. Of the active TB cases, 22 were diagnosed as resistant to the TB drug sensitivity test, with less than 5 of these cases diagnosed with multi-drug resistant TB. The success of Australia's TB screening program is reflected by Australia having one of the lowest rates of TB in the world. This low rate has been maintained despite large-scale migration from countries with higher TB rates than Australia, largely because of effective pre-migration screening by panel members and the activities of specialised, multidisciplinary TB services in the states and territories of Australia. This table displays TB detection rates per world region in the year 2019. The data only includes countries in which pre-migration screening caseloads were greater than 1,000. This is done to reduce the statistical margin of error and outliers that may skew the data, to provide more reliable results from which inferences can be made. The data reflects the country where a visa applicant undertook their IME and not the country listed on their passport, their country of residence, or their country of birth. As you can see, a significant majority of all TB cases identified were from Asia, with 566 cases identified in 2019 at a rate of 118 per 100,000 IMEs. While Africa had a much lower number of TB cases at 29, it was the region with the highest detection rate of 132 per 100,000 IMEs. The Pacific region, with its small caseload, yielded only 5 TB cases detected, but had the third highest detection rate at 113 per 100,000 cases. 19 cases were identified in the Middle East at a rate of 74 per 100,000, 5 in Europe at a rate of 53 per 100,000, and finally, the lowest in both absolute number of cases identified and rate of detection were the Americas, with less than 5 cases at a rate of 12 per 100,000. This table displays the top 5 countries in terms of TB detection rates during IMEs in 2019, with a comparison to World Health Organization TB incidence rates per 100,000 of each country's population. The top country for both TB cases identified and rate of detection was the Philippines, with 155 cases identified at a rate of 486 per 100,000 IMEs conducted. This is lower than the WHO incident rate of 554 per 100,000 of population. Second highest in terms of absolute numbers detected was India with 130 cases. However, these came from a significantly high IME caseload of 163,177, with a rate of only 80 per 100,000 screened. Again, this is much lower than the WHO population incident rate for TB in India of 193 per 100,000. 94 TB cases were identified among Nepalese applicants in 2019 from a caseload of 35,489. Thus, Nepal had the second highest TB detection rate, both for per 100,000 IMEs and per 100,000 of country population, with a higher detection rate amongst IMEs than in its general population. Likewise, Vietnam, the 5th highest with 51 TB cases detected from an IME caseload of 21,537, also had a higher TB detection rate of 237 per 100,000 IMEs compared to its country incidence rate of 176 per 100,000. While China was 4th in terms of TB cases identified, with a high IME caseload of 114,733, it was the lowest in terms of both detection rates per 100,000 IMEs conducted and per 100,000 of country population, according to WHO data. Thank you. This concludes the overview of updates to Australia's Visa and Migration Health Screening Program and policy initiatives. I will now hand over to Semra Capelli, who will provide a comprehensive update on matters regarding offshore Australian panel management and assurance.